Hello, everyone, and thanks for joining us today. My name is Marianne Stager. I'm your moderator, and I am the Director of Public Sector and Labor Strategy at Willis Towers Watson. I'm excited to welcome you to our program. Today, we'll be talking about something that's probably top of mind for most people around the country working with healthcare, sustaining public sector retiree healthcare in the COVID-19 era and beyond. But before we get into our program, which I'm very excited about, I want to go over a couple of housekeeping items. We encourage you to ask questions through the presentation by using the Questions tab located at the bottom of your viewing screen. If you experience any difficulties with the technology or slow bandwidth, you can also refresh your connection just by hitting the refresh icon. And if that doesn't help, there's also a help icon that you could click where a member of our support team will assist you. So again, thank you for joining us. I'm going to get started by telling you a little bit about myself. If we could go to the next slide, and our speakers as well. You could see we are very fortunate to have some folks who have worked with ending their group Medicare plan and moving to an individual Medicare marketplace or exchange. Those words are used interchangeably, marketplace, exchange. This is for Medicare enrolled folks. This is not the pre-65 Affordable Care Act exchanges. I'll let Laura and Nancy from the Nevada Public Employees Benefit Program introduce themselves. But first, I'm going to make a few comments myself. I have spent about 35 years advocating for public employees, first in my career with AFSCME, the labor union, and then as the healthcare director at the Ohio Public Employees Retirement System, which much like Laura and Nancy, although after they did it, I moved our retirees to the individual Medicare marketplace. Both of us used Willis Towers Watson. And I think we both will share with you we've had some pretty good experiences. If we could go to the next slide, I really feel very strongly about the commitment and the contribution that public employees make in our communities. I believe they are the strongest thread in the fabric that makes up our community. They take on very difficult jobs, especially during this pandemic. It's been really challenging for public employees. And if we go to the next slide, there's always been sort of a trade-off that public sector employees don't make the most money. You're not going to get rich in that career. But when you retire, you generally have a decent pension and good retiree health care coverage. And that's been sort of the trade-off. That's what's kept people in those jobs for, 20 years or longer, and you see lower turnover in these jobs. But I think on the next slide, you'll see we're starting to see that erode. That deal is not there as much. And it kind of started with the new GASB rules, where you have to list your healthcare liability for your future retirees, or your OPEB liability, as it's called, on your balance sheet, which makes states and local governments not look as well positioned financially, and that could hurt their their rating scores, financial rating scores, and so that's been a threat to continuing these benefits. And additionally, ever rising healthcare costs. I don't have to tell this audience about that. And now there's been pressure to reduce your assumed rate of return. So to the extent you have funding for healthcare, that fund doesn't look as healthy as it used to. And guess what? Now we have COVID. And, state and local governments, resources that are coming in have been really, really hurt by this because there aren't sales tax, there aren't, those kinds of things, hotel tax, things that would normally be coming in to help fund state and local governments have really gone down. And it remains to be seen what this will do in the future for medical costs. Certainly people aren't getting as many hip replacements, knee replacements, elective surgeries now, but at some point there's going to be some pretty pent-up demand for that. And we expect there might be an increase in that. And of course, some systems are experiencing increased hospitalization costs due to the virus. We go to the next slide, please. I have always felt that when I was working in healthcare that you want it to be a group plan and you want it to be the largest group you could possibly be, because that's how you would save money. And when I was at OPERS, we had about 165,000 Medicare retirees, and yet our retirees were leaving our group plan because they found greater affordability on the individual Medicare marketplace. This slide simply talks about the richest plan you can enroll in today, which is the Medigap Plan G, and it just has a very small annual deductible, and after that, everything is covered at 100%. And you add a drug plan to it, your total monthly premium is around $160 to $200 a month. Now, that's the most expensive plan. Keep in mind, there are Medicare Advantage plans that are $0 premium, and those plans are very comprehensive. And while many of them have networks, we're beginning to see those networks broaden, and we're beginning to see more of a PPO-style option for Medicare Advantage plans, and really great care coordination for those who are seriously ill and need that help. So, the price savings there are just phenomenal, and I'll give you another example. I'll give you some examples about that if we can look at the next slide. And it is kind of hard to imagine, to think that individual Medicare plans are cheaper than group plans, but I would encourage you to go to your state Department of Insurance website and look up the premium and the coverages, and I think you'll see it's very comprehensive coverage at a very low cost. So in this slide, you see we have seen the opportunity for savings being between 10 and 25%. And of course, since these are individual plans, retirees get to pick the plan that is best tailored to their needs. And the spouses might even pick a different plan. One is healthier, the other one has more chronic health diseases. They might want something more comprehensive. We list some results there. We've seen the average annual savings for retirees in a mid-size, this is in the Southeast, almost $3,000 a year more in that retiree's pocket. That's pretty huge. That there's a couple of other examples there you could read for yourself, but the savings are pretty significant. If we could look at the next slide. And those were savings for the retirees. Now when we look at savings for the systems, well, you do see this huge reduction because, first of all, your medical trend goes down. You're no longer looking at the 6 and 7% medical trend we typically see in group plans, and often even higher for group drug plans. These individual plans typically go up in premium between 2 and 3% a year. And because your risk is really giving an allowance to pay for the premium, or a subsidy, whichever term you prefer, you can lock that in at one price and not change it, or you could increase it just a little bit each year. From what I understand about where OPERS is, they have not had to increase theirs because of the inflation being so low. And people have some pretty hefty balances. They're actually looking at decreasing it, what they give as a monthly stipend or subsidy. So this immediately reduces your OPEB liability. It lowers your administrative costs because you're no longer going out to bid every 3 years or 5 years if you're so fortunate that you can wait that long. And you don't have to do the vendor management that we typically see when you have a medical vendor, a drug vendor, a vision, a dental, and then you bring in auditors. All that goes away. You have one-stop shop, and that is your Medicare Exchange, who does all the contracting with the carriers and also manages the reimbursement. So, we've seen plans save $12 billion in their OPEB liability. We've seen a mid-sized city reduce their OPEB by 319, and you could read the last number there. But the savings are significant for both the retiree and the system, which is why we call it a win-win solution. If we go to the next slide, which I think is my final slide, just a real quick overview of how this works. So the plan sponsor decides we're going to give the retirees in a reimbursement arrangement, a health reimbursement arrangement, which is a notional account. We're going to give them X number of dollars a month, $300 a month, for example. And then that retiree is given a lot of education about which plans they might want to select. And the Medicare exchange or marketplace that you work with will actually help them with that telephonically, or if the retiree wants to do it on the computer by themselves, they certainly can do that. But they get to pick which plan is best for them with pretty sophisticated software that asks the retirees a couple of questions about how often they use healthcare and whether or not they travel. It will, help direct them to the plan that's best for them and show them their monthly and annual costs that are anticipated based on their specific drug use, based on how frequently they go to the doctor. So then they actually get enrolled in that plan. And then there's a whole reimbursement process. Typically what happens is the plan that they pick, the retiree pays that premium to that plan. That plan then says to the Medicare exchange, hey, we got Joe's premium. Then the Medicare exchange looks in that person's HRA balance and puts that money right back in their checking account. It is a little set it and forget it. And retirees really do like that automatic reimbursement feature. And then going forward, there's ongoing advocacy that if the retiree needs some help with enrolling into a different plan during the next annual open enrollment, or perhaps they've lost their ID cards, or perhaps their insurance carrier isn't approving something and they want help with appealing it, a good Medicare exchange will help them with that and provide them with that lifetime support forever. So that is a little bit of overview I went through rather quickly because I really want you to hear from folks who have lived this experience. I have as well, but it's always good for me to hear how other colleagues went through this. So I am going to turn this over to Laura and Nancy.
Thanks, Marianne. So good morning or afternoon to some of you. My name is Laura Rich, and I am the Executive Officer of the Nevada Public Employees Benefits Program. I'll start out by providing a little bit of background on myself, and then I will let Nancy introduce herself. So I've been at PEB for almost 5 years now. I was previously the operations officer and was appointed as the executive officer in March, 1 week before the World Health Organization declared a pandemic, so lucky me. Prior to that, I spent some time at the Nevada Silver State Health Insurance Exchange, so that's the Affordable Care Act exchanges that were implemented in 2013. And I was part of that team that not only dealt with the chaos of that implementation and the challenges of that implementation, but also I stuck around to help Nevada partially transition onto that healthcare.gov platform. We became one of the first states to become a federally facilitated state-based exchange. Also, prior to that, I spent some time within the state service in Medicaid and also with our Division of Aging as well. So I have some background in a lot of different healthcare areas. Nancy, would you like to take a moment to introduce yourself?
Sure. Thank you, Laura. And thank you, Marianne, and the rest of the team from Willis Towers Watson for asking me to participate in today's presentation. As Laura said, my name is Nancy Spinelli, and I am the Quality Control Officer for the Nevada Public Employees Benefits Program. In my current role, I oversee program compliance with federal and state laws and regulation and the administration of the self-funded plan benefits. This fall will be my 20th anniversary working for the program. And I was there during the time of the transition to moving our Medicare retirees over to the exchange. So hopefully this will be very helpful for you all.
All right, and if we can go to the next slide, we'll go over our agenda for today. So we'll be covering a little bit about PEB, who is PEB, why the retiree changes to healthcare were needed, the solutions that we considered in that process, and what we ended up implementing, as well as the benefits, a little bit about the benefits of what we've found on that individual Medicare marketplace and our results. And then I think most importantly of all, those key takeaways that the lessons learned throughout our implementation and process into that transition. So if we can go into the next slide. An overview of PEP. So this first part provides a little information about who we are. We're an employer-sponsored group health and life insurance program providing benefits to approximately 45,000 primary participants and 28,000 dependents. About 40% of our population is made up of retirees, and about 12,000 to 13,000 of those are on the Medicare exchange today. We are governed by a 10-member board whose main mission is to provide employees, retirees, and their families with access to high-quality benefits at affordable prices. So if we can go to the next slide. And Nancy, I think were you going to do this slide?
Thank you, Laura. I appreciate the opportunity to share the experience that Nevada PEB had when we transitioned retirees to the exchange. Prior to the transition in 2011, PEB had approximately 27,000 active employees and 17,000 state and local government retirees enrolled in the plan. Our plan options at that time included a self-funded PPO plan with an $800 individual and $1,600 family deductible. We also had 2 regional HMO plans, one in Southern Nevada and one in Northern Nevada. In addition to these plans, we offered 2 regional Medicare Advantage plans to our Medicare retirees, one in Northern and one in Southern Nevada. Next slide, please.
So in Nevada, similar to the rest of the nation, we were suffering from an economic recession. The difference, though, in Nevada is that recessions tend to hit Nevada much harder than in other states because of our reliance on tourism and gaming. The state at the time was projecting a $3 billion shortfall on a $7 billion biannual state budget. So PEB specifically was projecting an $85 million gap between what the state was approved to subsidize and the amount that was needed to maintain those current benefits. The only way to make up that difference was for participants to make up the difference in premium rates, which would have resulted in very significant rate increases, or by making changes to benefit levels. PEB chose the latter. So if we can go to the next slide. The solutions we considered at the time, we had a lot of things on the table, right? So we had a low deductible PPO plan, and so what we looked at was maybe increasing those deductibles and the co-payments and co-insurance and all of those out-of-pocket maximums for the existing self-funded low deductible health plan. We also looked at replacing that low deductible PPO plan with a self-funded consumer-driven high-deductible health plan. At the time, this is where employers were going, right? Everyone was introducing those high-deductible plans. The plan we looked at included a $1,900 individual and a $3,800 family deductible, and a $3,900 individual and $7,800 annual out-of-pocket maximum. We also, with that, introduced some HSA options as well with that. So we looked at also increasing participant premium cost sharing. We looked at eliminating or reducing other benefits. So, for example, our life insurance, vision, and dental, things like that. And the biggest one was we looked at those Medicare retirees and what we could do with the Medicare retirees. So we looked at transitioning them to that individual marketplace. If we can go to the next slide. In the end, PEB actually implemented all of the options. We did reduce dental benefits. We scrapped that low deductible plan and moved to what at the time was becoming a more popular option among employers, which was that high deductible plan. We also reduced the co-insurance on the high deductible plan from 80% to 75%. And to help alleviate some of those costs, as I said, PEB added a health savings account and health reimbursement arrangement options with employer contributions depending on that tier of enrollment. We also adjusted the cost sharing for the HMO plan by raising the participant share of that premium versus what the state was subsidizing that plan. But the disruption didn't stop there. PEB also decided to transition all of the Medicare retirees to a private Medicare exchange through Willis Towers Watson. And we provided an HRA contribution, as Marianne mentioned earlier, to that group, and it was calculated based off of a years of service calculation. So next slide.
The benefits of the private Medicare exchange. The Medicare exchange allowed PEB to honor its commitment to continuing covering our Medicare retirees by giving them greater plan options at a reduced cost and the flexibility to personalize their coverage based on their individual health care needs. In addition, the exchange, in part, helped to reduce OPEB's liability and administrative burden, and Laura will go into details about the OPEB liabilities later in the presentation. Next slide. The benefits of the exchange, there's expanded plan options. Retirees have greater plan options and added flexibility to personalize their coverage based on their individual health care needs. The exchange offers Medicare Advantage plans, Medicare Supplement plans, Part D prescription drug plans, and a variety of other voluntary products through multiple carriers. There's larger risk pools in the individual market, and the risk pool includes all Medicare beneficiaries enrolled in policies within a state or county versus PEB's smaller retiree risk pool. Therefore, with a larger risk pool, the premiums are typically lower. Retirees can choose how to use their HRA dollars. As Laura mentioned, our PEB retirees receive a monthly contribution to their HRA based on their years of service, and the HRA can be used to reimburse them for their premiums and other qualified out-of-pocket health care expenses. Guaranteed issue in pricing. PEB's retirees were losing group coverage as they transitioned over to the exchange, which triggered a special enrollment opportunity, thus allowing them to purchase guaranteed issue plans regardless of their health status. And then, as Marianne mentioned earlier, there's reduced administrative load. The exchange assumes the administration on the plan options, the enrollment, and the HRA administration. Support from licensed benefit advisors. Retirees receive support from trained licensed benefit advisors who can assist them with questions and provide ongoing support and advocacy throughout the enrollment process and post-enrollment. And then reduced health care spending for most retirees. Three things that were very important to the PEB board in making the decision to transition our retirees to the exchange were, number one, to ensure they had at least the same or better coverage than the group health plan. Two, the cost of the new coverage options. And three, the customer service for the retirees. Most retirees save between $300 to $1,800 annually on premium costs and out-of-pocket expenses through the exchange. It also allowed PEB to reduce its annual subsidy contribution without reducing benefits by providing a monthly HRA contribution in lieu of premium subsidy, thereby reducing the subsidy by almost half for the Medicare retirees. And then, again, it reduced PEB's OPEB liability by transitioning the Medicare retirees to the exchange, which, again, Laura will talk about later. Next slide, please.
by taking the combination of steps of moving the active employees from a self-funded low-deductible PPO to a high-deductible plan, and then again by moving those Medicare-eligible retirees off the PEB self-funded plans and onto the Medicare exchange, PEB was not only able to close that $85 million gap, but retirees also saw significant savings as well and increased choices. Retirees were saving anywhere from, I know Nancy said $300 to $1,800, but for the most part they were on average anywhere from $1,200 to $1,800. And not only that, but now they found themselves being able to select from a list of coverage options that better fit their own individual needs. So they were not pigeonholed to the couple plans that PEB offered their active employees. So next slide, please. The state's OPEB liability, so for those of you who are not familiar with the acronym, it stands for Other Post-Employment Benefits. It was reduced significantly. Moving those retirees onto the exchanges, you can see, decreased the present value of benefits by $1.27 billion and the actuarial accrued liability by $0.48 billion. So this move is really significant for governments that are struggling with those unfunded liabilities. Next slide, please.
Thank you, Laura. Yeah, Laura is correct as far as the retiree savings. It was the $1,800, I believe, that Laura just mentioned. I was reading my notes incorrectly. Things to consider prior to the transition. How will you communicate with your retirees? This is a major life change. This was a major life change for PEB's retirees. They were accustomed to contacting the PEB office with concerns about their insurance benefits. And many of the retirees believed they were being dumped by the program. So it was important that they understood why they were being transitioned and the benefits to them by moving to the exchange, which included the choice of comprehensive coverage, expanded plan options with affordable premiums, and we worked very closely with our retiree advocacy groups and invited their leadership to attend our educational sessions. During the transition, our motto at the time was no retiree left behind. That meant any retiree who failed to contact Towers Watson to complete their enrollment received multiple outreach attempts from the PEB staff, from Willis Towers Watson's staff, and it also includes certified letters to ensure that they all completed their enrollment. Will your enrollment be mandatory or voluntary? PEB required mandatory enrollment on July 1st of 2011. However, we ended up extending that deadline through September for a handful of retirees. And we still today require Medicare retirees who have free Medicare Part A and B, then they must transition to the exchange. And then, will you provide an HRA contribution? PEB's liability was reduced in part due to the transition of the Medicare retirees. And then the PEB provides that monthly contribution based on the years of service, beginning with 5 years to a maximum of 20 years. And will you provide access to other employer-sponsored benefits? PEB offers a voluntary dental plan that our Medicare retirees can enroll in, along with other voluntary products. Next slide, please. The education and communications were very critical during this transition time for our retirees. We knew it would be a major life change for them, and they were used to having a couple of plan options to choose from during open enrollment, and their prescription drug and dental benefits were bundled with the medical plan, so they didn't have to worry about selecting a separate drug plan or dental plan. We wanted to ensure the transition was as stress-free as possible. Therefore, we collaborated with Willis Towers Watson to create our initial communication plan beginning in September of 2010 in preparation for the July 1st, 2011 transition date. The initial phase of the communications included mailings and educational sessions to introduce Willis Towers Watson's to the retirees. The sessions included high-level overview of the exchange, including examples of plan options, carriers, premium costs, the HRA, the transition process and time frame, and the types of communications the retirees could expect to receive in the mail in the coming months in preparation for their initial enrollment call with a benefit advisor. During that initial phase, we had 5,200 retirees attend the presentation. The second phase of the educational sessions included more detail regarding Medicare Parts A and B and examples of plan options, carriers, premium costs, qualified expenses, enrollment timeframes, and more detail on Medicare Advantage plans versus Medigap plans. And we also educated them on the Medicare open enrollment. The third phase of the transition was held during PEB's normal open enrollment period. We held separate classes for Medicare retirees, which include all of the information from the second phase of the communication plan. And during the open enrollment period, we had 2,200 retirees in attendance. Next slide. After completing the initial enrollment call with the benefit advisors, retirees were randomly selected to participate in a transition survey. As you can see on the slide, 4,222 retirees out of 10,316 at that time were randomly selected to participate, and of those, 1,688 agreed to complete the survey. On a scale from 1 to 10 on satisfaction with the service that they received from Willis Towers Watson, more than 65% selected a 9 or 10, and less than 5% gave the service a 4 or less. Next slide, please. For ongoing retiree outreach, after the initial transition in 2011, in the spring of 2015, PEB staff offered additional educational sessions throughout the state. I don't have the attendance numbers with me here today, but those sessions were very well attended. In addition, PEB and Willis Towers Watson offers educational sessions twice a year in the spring and in the fall, just before the Medicare open enrollment period. The PEB office is located in Carson City, and due to the number of retirees aging into Medicare, we believed it was necessary to offer on-site informational sessions for newly retiring employees as well as retirees aging into Medicare. Those classes are offered weekly and are also very well attended by the retirees. In addition to that, we have an on-site HRA specialist who works in the PEB office, and she works for Willis Towers Watson to assist our PEB retirees with issues that they have with their HRA claims and reimbursements. Next slide, please. This slide provides a total enrollment since the initial transition in 2011 through June 1st of 2020. You can see the most popular plan choice for PEB retirees is the Medicare Supplement or Medigap plan with 10,262 enrolled and an average premium of $147. The Medicare Advantage plan with prescription drug coverage enrollment is at $2,589, and the average premium there is $23. Some of those Medicare Advantage plans have zero premiums as well. The Part D prescription drug plans, enrollment there is $7,647 with an average premium cost of $25. And then you can see the dental coverage. The average cost there is $36. That's a voluntary product, as well as the voluntary vision. The average cost is $14. Next slide, please.
So So this next slide is we'll talk about our current plan options. I'll start out by saying that one of the lessons learned is that you want to stay away from overcomplicating the eligibility and program rules if you can absolutely prevent it. Sometimes in the public sector it's unavoidable, but if you take anything away from this, it's to keep it as simple as possible. PEB, unfortunately, has some complex eligibility rules, but it's meant to really benefit retirees and their families. For example, our pre-65 retirees are able to remain on the PEB self-funded program and on our plans to select any of those options available, that are available to the active employees as well. Medicare eligible retirees are also allowed to remain on the PEB plans if they have dependents who are not yet Medicare eligible. So for example, if a retiree is 65 and Medicare eligible, but let's say his wife is only 60, they can both remain on either the high deductible plan, EPO, or HMO plans until the time when the wife becomes Medicare eligible. Those retirees who will never qualify for free Part A can also remain on the plan indefinitely as well. PEB requires them to purchase Part B, but we do provide a $135 credit for them to do so. So once they're on the Medicare exchange, retirees have a variety of options available to them, and just like Nancy just described, including those Advantage plans, Medicare Supplement or Medigap, and Part D prescription drug plans. And as we mentioned earlier several times, PEB provides those retirees with HRA funding based on that years of service calculation. So currently, a retiree with 20 years of service on the exchange receives a $260 per month subsidy, and they can use this to pay their premiums or any eligible out-of-pocket expenses. And like Nancy mentioned, since some plans have $0 premiums, many retirees have accrued large balances in their HRA accounts. And so that HRA funding is plenty to cover their out-of-pocket expenses. If we can go to the next slide. So key takeaways. Now that we get to the lessons learned part, which is personally the part that I'm usually most interested in when I'm considering a major transition like this, because you can avoid repeating mistakes that others have made, and it just makes that transition so much easier. So first off, staying heavily involved in that transition is key. You don't want to do this during a time period where you cannot commit to focusing your efforts on a transition that's significant. So for us, for example, we didn't want to do it while we were in the middle of session or even preparing for session, right? We wanted to do this on an off year. Nevada has a biennial. Our legislature meets every 2 years. So we did this on an off year. You also want to make sure that you follow up on issues right away and that from the get-go you establish reliable data processes. I can't even begin to tell you how much easier it is to build this process right from the beginning and attempt to build it so that there's flexibility rather than having to deal with those changes later. This way, if there's any program changes or all of a sudden maybe you need to collect new data, the processes, if they're flexible and built that way from the beginning, can accommodate the changes. Also, staff training is huge. Although in our case, members are able to call the Medicare Exchange customer service line directly, PEB also employs call center staff who receive calls on this every day. I'll tell you that Medicare process is, we receive a lot of calls internally here at PEB from retirees, either transitioning into the Medicare process or retirees that are already on Medicare, and our staff does help those members and handholds them through that process. Staff must be prepared to answer questions and must be able to answer those customer service issues, or assist also with those customer service issues. Communication is also extremely important. Whenever you introduce major change, you want to make sure that you communicate early, often, and in as many ways as you possibly can. PEB uses many different methods to communicate. So we use paper mailings, we email, sometimes we do both. And we also enlist the help of some retiree advocacy groups to get the message out as well. You have to remember that you're dealing with an older population in this case, so while some may be receptive to email, there are a lot that appreciate getting a notification in writing through the mail. Also, managing perceptions is important as well. I'll be honest, to this day, I still hear retirees refer to the transition as, PEB farmed the retirees over to the exchange. And so that indicates to me that we probably could have done a better job at managing this perception. But I think overall, though, most Medicare retirees today are very satisfied with their options and the service they receive as well. And I think if we go to the next slide, that is the end of our presentation. Marianne, if you want to take it over from here.
Great, thank you. What interesting and really good information. And we've had a lot of good questions. First one says, this is truly a win-win for employers and their retirees. How can it be applied to active employees that are Medicare eligible and I'm presuming still working age 65 plus? I'll take a shot at answering that. There are very strict rules about Medicare, and if somebody is working and eligible and, presumably enrolled in Medicare Part A, their employer's health care has to be the primary payer. These are called Medicare secondary payer rules. And if you were to try to force an active employee onto this model and off of your group plan, you would be in serious trouble and in violation of Medicare secondary payer rules. So this really, the model we've been talking about works for folks who are retirees. Now, there are other options that are out there that do help employers. One is called through ICRA that can help them use a model like this for active employees, but that's a whole nother program that we really should do, and doesn't really apply well to the public sector, but basically this model is for folks who are retired. There's another question I'm going to ask for Nancy or Laura to answer. How many Medicare eligible participants in your plan?
So right now, I believe those that are participating on the Medicare exchange, it's somewhere it's about 12,700-ish, if I remember correctly. Now, that number changes month to month, right? But it's right around that number. We also, as I said, we do have Medicare eligible retirees who remain on our plan because they have dependents, that are not Medicare eligible. And I don't have that number right off the top of my head, but I'm happy to get that to you at a later time.
Yeah, and let me just add that this model is scalable. If you have 100 retirees, or you have, like I had at Oprah's, 142,000 retirees. So it's really scalable either way. Let me just mention, we do have another slide up. If you would like to learn more about this, and I'm going to go back to the rest of our questions in a minute here. If you would like to know more about whether or not this model can save you money, we would be happy to do a financial impact analysis, which would give you both the numbers savings for you as a plan sponsor and for your retirees, okay, and also what your OPEB reduction would be. And we will probably just send information out about that. And yes, we will be sending you the slides and a link to the audio as well. I know there were a lot of questions about that. We'll certainly share that afterwards. And we'll share with you the form if you wanted to request a financial impact analysis. There's just some census data that's taken in your plan design that's taken, and then our actuaries actually do the modeling of that. So we'd be happy to do that free of cost for anybody. Okay, here is another question from a trustee. Is it mandatory for your retirees who do not have Medicare, and I'm presuming this means Medicare Part A, because I think Colorado's a non-Social Security state like Ohio, to pay their own, so is it mandatory for those people to pay their own Medicare Part B to register in the program, and is it mandatory for your non-Medicare retirees to pay their own Medicare Part B costs? I think you answered that, but let's go over it again, Laura or Nancy.
So this is Laura. Yes, it is, and so those that are not eligible for free Part A, we actually provide a credit of $135, and that has actually increased, as the cost increases, PEB attempts to match it. And so currently we do provide those retirees the $135 to purchase that Part B. I don't know, Nancy, if you want to add anything to that.
No, that's correct. If they don't qualify for the free Part A, they're not required to purchase Part A, but they are required to purchase Part B if they're staying on the group plan, obviously, and then they would receive a premium credit to offset the cost of their Medicare Part B.
And let me add another nuance to this. So in these states where, you had people who were hired before April 1st of 1986, they were not required to pay the payroll tax, for Medicare Part A. When you do that, obviously, when you turn 65, you get Part A, the hospital coverage, for free. But if you started at a job in the public sector in some of these non-Social Security states, then if you never changed job, you were never given the opportunity to actually enroll, to pay for Part A, and therefore you can't get free premium Medicare Part A. We did the same thing in Ohio that Nevada did. We kept them in a group plan until we did the math, and we realized that if we actually reimbursed our retirees who did not qualify for premium-free Medicare Part A, if we reimbursed them for the cost of that premium, plus there's a one-time 10% penalty, and then enroll them into our Medicare exchange, or connector we called it in Ohio, that was actually cheaper for us. And the retirees wanted us to do that. They saw the savings that everybody else was getting, and they actually did a postcard drive to the legislature to change a piece of the law that would allow them to do this. And so they did that. So you really do want to look at which opportunity is more affordable for you and for the retiree. OPERS does also require folks to be enrolled in Medicare Part B. They used to reimburse for it. They do not. However, the amount of subsidy that's given to retirees generally does cover that premium after they pay their premium for their individual plan and drug plan. So there's different ways of doing that. All right, we have another question. Yes, go ahead.
Let me just add one more thing as far as the state of Nevada. We do, if a retiree doesn't qualify for free Part A on their own behalf, yet they've been married for 10 years to a spouse who does qualify, then once that spouse turns 65, then we would require the retiree to enroll in Medicare through the spouse.
That's a very good point. There are a lot of people who don't realize that they at least have partial credit from other jobs, that maybe they wouldn't have to pay the full Part A premium, or they have it from a spouse, even from a former spouse. And so, going through a process to identify those sometimes can be very helpful. We have another question. This person would like to know, how many different tiers of HRA do you provide, and what is the range of the amount provided? I'll let Nevada go first, and then I'll share what I know about what we did in Ohio.
So this is Laura. On our Medicare exchange, like I said, it's based on a years of service contribution, and so, but there's a couple different things because the legislature made some changes. So if you're hired after a certain date, there's some exceptions to this, right? Typically, most people fall under the, basically it's $13 per month per year of service, beginning with 5 years. So if you've got less than 5 years of service, then you get zero. So 5 years of service equals a $65 a month contribution, up to 20. That is where we top out. So the most a retiree can get is $260 a month of HRA funding from the state.
And when I was in Ohio, I believe it has changed now, but initially the average retiree received about $330 a month. I talked to a retiree not too long ago who was very nervous about the fact that OPERS was contemplating reducing the allowance. And again, theirs is based on years of service and age at first enrollment into healthcare. The older you are, the higher premium you get because you delayed your enrollment till a later time in life. But, she was very concerned. And I said to her, well, how much money do you have in your HRA? She says, $8,000. I said, what are you going to use that for? I don't know. Maybe I'll need it. I said, you probably have more money than you need, and it's OPERS needs to be frugal, like all systems do with their money. But it's the employer's discretion what that amount is. Unless you have a collective bargaining agreement, you have to negotiate that, or perhaps statute. And there's a lot of other questions for an employer. Do you want that money to roll over every year? In Ohio, it does. In other places, it doesn't. Do you want those retirees to use those dollars for premium? What about for the Medicare Part B premium reimbursement? And what about out-of-pocket expenses? The IRS allows the employer to make those decisions and, decide whether or not those would all be permittable or just the premium.
Marianne, I'd also like I'd like to add one more thing to that too. Since you were talking about rollovers, something that PEB actually just recently in the last month the PEB board has made a decision on is to cap those HRA accounts, and the reason why is because we had many accounts that had accrued up to $25,000, and we had retirees who were not using the funding whatsoever, probably because they were in $0 premium plans, and just had no out-of-pocket expenses, or maybe they just didn't need it. And so we chose to cap it effective next year at an $8,000 level. And so we allow these funds to roll over every year up to $8,000, and then at a certain time of the year we do the cutoff. And so if you have $9,000, it's rolled back to $8,000 at that time. And we just the board just approved that, so it's still in we're now in the process of communicating that to all of our retirees.
Yes, that's very, very true. You can certainly put a cap on it. Now, another question we had, and I think you mentioned this, Nancy. Do retirees have to go through medical underwriting when they leave your group plan?
No, they don't. Retirees are not required to go through medical underwriting because they receive a special enrollment opportunity when they're losing group coverage, and that gives them guarantee issue enrollment in plans.
Okay. And also someone wants to know, does Nevada cover spouses as well as retirees?
We do cover spouses and retirees. Now, the spouses that are enrolled through the Medicare exchange are not subsidized. There's just the monthly contribution for the retiree, but they do transition to the Medicare exchange once they become Medicare eligible as well.
And can the spouse get reimbursement from the retiree's subsidy?
Yes, they can, as long as they're they're married, of course, and file jointly, then they can receive reimbursement through the HRA.
Yeah, so imagine this: if you're giving even $200 a month, and you're both enrolled in a $0 Medicare exchange program, your out-of-pocket expenses are going to be, $10 co-pays to a doctor, maybe $25 to a specialist, $3 and $10 and $20, maybe $30, depending on the drug copays for drugs, and that's what you're going to get reimbursed. That's what you're going to use that money for. So you very easily could use this money for both folks. Another question we have is, how is it possible that these individual plans are so much cheaper than a group plan? Was that something that Nancy wants to answer?
Yeah, I'll take that question. I think it's a very good question. You may want to add on to this, Marianne. However, from my perspective, the plans are cheaper based upon the risk pool. The individual marketplace is also more competitive. The individual Medigap and Medicare Advantage plans compete with each other to enroll retirees who can switch from a Medigap plan to a Medicare Advantage plan or between Medicare Advantage plans during open enrollment each plan year. Competition among the plans help retirees by keeping prices low and offering beneficiaries more choice.
Yeah, you're right about that. I mean, when I think about how large our pool was, I thought we were pretty big and powerful, and we were in many ways, but we weren't as big as 42 million lives, which are the number of people enrolled in the individual Medicare plans. And, for the next, I don't know if it's 10 or 15 or 20 years, but for the foreseeable future, we're having 10,000 Americans turn 65 every day. And that means every day this market, this pool, gets 10,000 new lives that are on the young spectrum. And, we don't necessarily always see that in our individual plans, particularly in those places where we've cut off retiree health care for future hires, something that kind of breaks my heart, but it does happen. And it's such a large pool. It's a marketplace that's been around for decades. It's very stable. And, the way these rates are set is all of the plans have to sort of guess what their rates should be, knowing they're competing, and then they submit their rates to state departments of insurance and to CMS, and then those are their rates for the year. And it's been a very stable and very affordable marketplace. And again, go to your Department of Insurance, look up what a Medigap Plan G is, and look at the very rich coverage even in these $0 Medicare Advantage plans, and see how well that works for you. Was this, Nancy, I'm going to ask you this question because you were there. Was this change difficult for retirees, and how did you reach them all?
It was a difficult transition, I believe, for a small percentage of the retirees. There were challenges, of course, but the biggest challenge, I believe, was to get to earn their trust, and so that they understood that they weren't being dumped by the program, and that the benefits of moving to the exchange provided them with expanded plan choices, including prescription drug coverage and other voluntary benefit options. PEB has a very small staff of 34 employees, so this was a huge transition that would never have happened as smoothly as it did without the expertise of Willis Towers Watson's management staff and the licensed benefit advisors assisting the retirees through this transition.
Yeah, and I'll say, and I think this is probably one of the last comments we'll have. We're almost at the top of the hour. We did a lot of outreach, just like Nevada did. Willis Towers Watson called these people, emailed them, mailed them. I held teletown hall meetings over the phone with them. And my biggest fear was January 1st, we were going to have tens of thousands of people who did nothing. Well, the truth is we did have thousands who did nothing, and they called us and they said, I slept on it. I knew I should have done something, but I didn't. Here's the really cool part, and we did not advertise this. You have a period of 2 months after your initial 90 days of guaranteed issue. You have a period of 2 months of guaranteed issue for a enrollment prospectively, so into the next month. And so we enrolled, Willis Towers Watson then enrolled them all through January and February. And then towards the end of that, we ended up with about 200 people we couldn't find, and we actually hired folks to go door to door. We came down, most of the people said, leave me alone, I've got TRICARE, I've got my spouse's care, or whatever. And then we ended up with 11 people we never found. They never came back to us and said, hey, why don't I have insurance? So who knows, did they pass? Did they, was there some frauds there? We started researching, but you really can end up with no retiree left behind. Well, I'm going to wrap up for us. I really want to thank Laura and Nancy. What a phenomenal job. So good at explaining a somewhat difficult concept, but a win-win for employees like one of our, and the systems, as one of our commenters made. Don't forget, if you would like we'll be mailing you the slides and a link to the audio, as well as the opportunity to request a financial impact analysis. And at the bottom of our slides are contact information. I'm sure we're all willing to answer your questions should you have more. Thank you very much, everybody, and have a wonderful day.